primary central nervous system lymphoma are an unmet medical need. New drugs are necessary, new clinical trials are necessary, and for that we need to measure response. What does the tumor do in response to those treatments? Lauren Abrey and her colleagues have in 2005 published response criteria that are still used. They have 4 sources of information: the brain image, the glucocorticoid dose, mostly dexamethasone, the ophthalmology examination, and the cerebrospinal fluid cytology. Their categories of response include complete response, CR. That basically means there is no indication of tumor in any of those examinations, and the steroid dose is 0. No dexamethasone. They have a category that most response criteria don't have, and they called it CRU, unconfirmed complete response. And in that case, that includes patients that have all the other category requirements for CR, yet the steroid dose has not gone down to 0. Or there may be minor abnormalities on the image or minor abnormalities in the ophthalmology exam, yet the CSF cytology has to be negative in all of them. They have a category of partial response, which means the tumor is much smaller, and much smaller in this case means 50% less or better. In those cases, steroids may still be there. The dose is irrelevant for the category. The eye exam may have minor abnormalities or be normal, and the CSF has to be negative for those that have central nervous system tumors. There are others where there either is nothing left in the brain or there was never anything in the brain. It was only in the eyes. In those, the ophthalmology result must be much better than before, and CSF cytology may be persistent or suspicious, and it can still be called PR. There is the worst category of progressive disease, which means the tumor is larger. And when you see it in brain image, larger means 25% increase or more. Obviously, those patients may be on steroids. The eye exam may have new tumors or recurrent disease or worsening of the disease, and also the cerebrospinal fluid may be worse. Further, there may be new lesions in the central nervous system or elsewhere. Any of those findings will make it progressive disease, the brain, the eye, the CSF, or elsewhere. Other than this table, the paper specifies further details of the response criteria, and the most important I put together down here. The imaging methods, the details of that are a common question, and the paper mainly talks about MRI, magnetic resonance imaging, but further details are not really provided in the paper. There is a common question if confirmation is required. And in this case, the word confirmation means something different than in the U for CRU. In this case, it means a tumor that has disappeared may recur very fast, and we don't want to call that a CR. Therefore, if the criteria for CR are met, a further later image, couple of weeks or months later, needs to be repeated. A further assessment needs to be repeated. And in that assessment, it must be confirmed that there is no tumor. Some response criteria require that, others don't. This one, the Abrey 2005 criteria, require it for CR, only for CR. There's now often a question is, how are the measurements done? And this may be done in 1 or 2 dimensions or 3 dimensions or volumetry. This question is left open in the Abrey 2005 paper. And then there is a modern discussion around the term pseudo-progression. That discussion has become alive after that paper was published. The term is not discussed in the paper. This was the short version. If you want to understand what all this means, listen to the rest of the video. Welcome, everybody. You have clicked in a series of teaching slide presentations explaining clinical drug development in oncology. This time we will give an overview of PCNSL, describe the context of the 2005 response criteria in Principles of Response in Oncology, describe the follow-up paper, and end with a prediction in which direction the Medical Scientific Society will go in the future. My name is Johannes Wolf. This video is recorded in December 2024. Dr. Wolf, before the treatment, God has placed the diagnosis. So I was told when I was a young resident. I am pretty sure this is not true. Now, those diagnoses are human-made and they change with our technology. In the beginning, there was just the organ. There is lung cancer, prostate cancer, ovarian cancer, and there is lymphoma. Lymphoma as a disease that starts in lymphatic tissue. Among hematological malignancies, we differentiate between lymphoma and leukemia. Also, the biology of those two groups of diagnoses isn't that different. The leukemic cells don't grow in aggregates. The lymphoma cells grow in aggregates, form a stroma, blood vessels, solid tumors. The leukemia cells have given up on growing together and float in blood. Among leukemias, we have a great separation in the group of lymphatic versus myeloid and the group of acute versus chronic leukemias. So that leads to an acute lymphoblastic leukemia. That's a childhood disease, was one of the first diseases that was curable, obviously not in all patients. Acute myeloid leukemia occurs in children and in adults and requires quite intensive chemotherapy to treat. Chronic myeloid leukemia is a disease of the elderly, is very rare in children, does occur, and chronic lymphatic leukemia is in even older people and does not occur in children at all. This is a very slow-growing disease. Acute lymphoblastic leukemia is a very fast-growing disease. We differentiate those leukemias from lymphomas. Now, the classification of lymphomas is very confusing because it has changed so much. In the beginning, when the microscope was discovered, there was the classification of Hodgkin's lymphoma versus non-Hodgkin's lymphoma. Then immunodiagnostic methods were discovered, cytogenetics, and finally molecular diagnoses were discovered. And every time the classification systematic needs to be changed. Now, it doesn't need to be changed completely because often when we have new technology, we actually find out that the group of patients we put together as one diagnosis in the past still makes sense with the new classification, but not always. What you then find in the way we communicate as diagnoses is a mixture of this history and science and things that are moved forward. For lymphoma, nowadays there is typically a classification in Hodgkin's lymphoma to non-Hodgkin's lymphoma. Thomas Hodgkin was one of the greatest pathologists. He was one of the pioneers after the microscope was invented. He discovered that some lymphoma look relatively similar. The hallmark is the Reed-Sternberg giant cell, which looks different from the normal lymphocyte. By now, the Hodgkin's disease has been classified in further subgroups. And it is differentiated altogether from non-Hodgkin's lymphoma, which are more common. Hodgkin's lymphoma with 2.6 per 100,000 per year, non-Hodgkin lymphoma with about 10 times that many. Non-Hodgkin's lymphoma, then with the discovery of immune methods, could be mainly differentiated in lymphoma that are somewhat resembling B-cell biology from those that resemble T-cell biology. You know, the normal B cells are the cells that make antibodies. The normal T cells are the ones that kill on contact and, for instance, mainly kill the main defenders against cancer, while the antibodies are main defenses against virus infections. B-cell lymphoma are far more common than T-cell lymphoma. If you were to use this classification completely, Hodgkin's would probably go in the group of B-cell lymphoma. But we're not doing this. We're honoring Dr. Hodgkin's. We have Hodgkin's lymphoma, and that diagnosis will stay for a while. There are further subgroups of B-cell lymphoma, and there are many of them, and it is a confusing list with somewhat gray borders. Diffuse large B-cell lymphoma are the most common of them. Diffuse means they infiltrate in the tissue. The opposite to diffuse would be solid or circumscribed. The diffuse large B-cell lymphoma are not circumscribed. They tend to go into tissue, something that immune cells, lymphocytes can do also when they're not cancer cells. Large simply means the cells are big, and they are differentiated from small cell lymphoma, where the cells are small. The other classifications include follicular lymphoma. There is a classification of small cell lymphoma that is now being summarized together with CLL, chronic lymphatic leukemia. And you see here is another break of our classifications because the CLL is a leukemia, and yet it still belongs to the B-cell malignancies. There are two with M, mantle cell lymphoma, MCL, and marginal zone lymphoma, MZL. Both make about 10%. Burkitt lymphoma is rare. It is a childhood disease, very fast growing. Waldenstrom's macroglobulinemia is kind of the opposite, very slow growing. And then there is PCNSL. That again breaks the systematic because PCNSL is a classification that describes where the tumor grows, not the biology or even what they look like in the microscope. And I have summarized that here under B-cell lymphoma because that's where it normally appears. But that's only part of the truth because, primary means it occurred primarily in the brain and is not a metastasis. A metastasis would be called secondary. But primary central nervous system lymphoma are mainly B-cell lymphoma. There is a small group of them that actually has T-cell biology and needs completely different treatment. When we write clinical trials, we typically try to include patients that are as similar as possible, and we try to enroll those central nervous system lymphoma that are DLBCL in the microscope. Now, with this all changing and with words meaning different things in different contexts, you ask yourself, who owns the truth? And there is an answer to that in nowadays, at least. And the answer is the World Health Organization. They have a series of books that they call the WHO classification of, and then something after this. One of those is the hematopoietic and lymphatic tumors. There you find what most of the world of the medical scientific community considers the truth for classifications. And they have all those terms and they describe them in great details. Those chapters are very, very well written. They are written by experts in the field that have devoted their entire lives to a diagnosis and really know it. Now, they don't know what the future will bring, but for the time being, what they say is about the best that you can have as an overview. I recommend actually to buy these books in paper format. That's one of the few that are still worthy to have on your desk. Now, you've seen the most common diagnoses, but this is a confusing number of names, and they are even overlapping. What you see here is another way of understanding it. It came about when immune characteristics of tumors and tumor cells became solid. You're looking at a figure from Ryan and Wilcox published in 2019. We believe that the B-cell development starts with a hematopoietic stem cell that lives in bone marrow. That cell can differentiate in T or in B direction, and when it goes in B direction, then it leaves the bone marrow as a naive B cell enters the lymph node. Lymph nodes have germinal centers in the follicles, and in such a center, the cell decides to grow again and then looks different, is called a centroblast. Once it's finished, it looks different again, called a centrocyte, leaves the germinal center, and can become a relatively quiet memory B cell or a plasmablast, which grows again and makes many of them to then finally become a plasma cell, which is the ultimate producer of antibodies. Malignant diseases from the B cell line resemble those different cell development statuses. Acute lymphoblastic leukemia of childhood typically lives somewhere here. The naive B cell in lymph nodes resembles what the mantle cell lymphoma has. The Burkitt lymphoma, the childhood lymphoma that is responsive to chemotherapy, resembles centroblasts. The follicular lymphoma, centrocytes. The memory B cells resemble the chronic lymphatic leukemia or small cell lymphoma. DLBCL, the histological classification of diffuse large B-cell lymphoma, didn't completely fit when this was all figured out. It turned out that there are two subtypes that you cannot distinguish by the microscope, but you can distinguish them molecularly and with immunology. One is called the GCB, diffuse large B-cell lymphoma, and is relatively early in the development of B cells. That tumor, or if you speak it out, it says germinal center B cell, and the tumor is characterized by BCL2 and EZH2 alterations. It responds quite well to R-CHOP. That's a chemotherapy protocol. In contrast, ABC, diffuse large B-cell lymphoma, resemble a more mature cell. And what you find there is the NF-kappa B pathways activated. You can find MyD88 and CD79A altered. The prognosis of those tumors is not quite as good as the germinal center DLBCL. Primary central nervous system lymphoma belong in the group of ABC, activated B cell-like diffuse large B cell lymphoma by histology. So now you know primary central nervous system lymphoma are non-Hodgkin lymphoma, B cell type, DLBCL, more specific, typically ABC DLBCL. And those tumors are characterized by activation of NF-kappa B pathways. This is an overview of some of the NF-kappa B pathways. I took the figure from a publication on Guo in 2000, published in 2024. And you see, NF-kappa B can be activated by the B cell receptor, and CD79A is part of that receptor. It can also be activated by the toll-like receptors, and MyD88 is a part of that pathway. Transcription factors bind to the DNA, activate pathways there, and the pathways that NF-kappa B activates are mainly inflammation pathways. It can have regulatory components in either direction, but mainly it is pro-inflammation, activates immune processes, increases cell survival, activates cell proliferation. And if those pathways are activated without a ligand, without listening to the signals around, just activated all the time, then these cells can turn into cancer cells. That is one of the hallmarks of cancer, that it doesn't listen to the signals that come from the outside. The picture is a bit more complicated. NF-kappa B does many more things, and it does that not just in B cells, it also has significant components in myeloid cells. And if you read the entire paper, you will see how complex the story is. For now, Please remember B-cell receptor pathway, CD79A, toll-like receptors, MyD88, NF-kappa B, activation of pathway, proliferation of cells, turning to cancer. This is what a primary central nervous system lymphoma can look like. This is an MRI. More specific, it is a T1 weighted axial post-contrast MRI. Axial means the cut is horizontal if the person was standing. T1 is a way to do these images in which fat appears white and water appears black. Contrast enhanced means the image was done in the beginning without injecting anything, then contrast gadolinium was injected, and then some parts of the tumor or of the tissue appear whitish. That is then called contrast enhanced. So here you see these pieces being white, and you have to take my word for that this is contrast enhancement. You could only prove this if you saw the other image before the contrast was injected. This black area is water in the brain, the ventricle, that's normal, and in there you see something that's also white, also contrast enhancing, that is choroid plexus, also normal tissue. But these bubbles here and this bubble, that is not normal. That is lymphoma, primary central nervous system lymphoma, and here you see the source where the image was taken. In front of that lymphoma, you see the brain looks a bit different from the other side. It is darker. That is perifocal edema. It is water in the middle of the tissue, not as a fluid, but as a mushy infiltration of the tissue. Brain edema. The epidemiology is that the tumor is rare. It's only 0.4 patients per 100,000 per year. The risk factors include high age and immune deficiencies of various kind. They may come from inborn errors of metabolism or of drugs or infections. The symptoms are non-specific. Any type of brain tumor in that location would do that. Frontal tumors typically give a bit more of cognitive symptoms. Tumors more in the central obviously give more focal neurological symptoms. Primary central nervous system lymphoma can occur in the eyes and just in the eyes, and obviously then visual changes are important. The diagnostic is done by MRI, like this one, magnetic resonance imaging. The eye exam is important. The LP is the method to get the cerebrospinal fluid. It is a needle put in the back and reaching that fluid. But altogether, the real diagnosis nowadays still comes only from a biopsy, which is a surgery. It can be a small surgery, despite this being in the brain, but it still is a surgery. And then when you have the tissue from the biopsy, you can look in the microscope and you'll see DLBCL. And if the immunological phenotyping is done, then you see that it is ABC type DLBCL, at least the most typical. The molecular characteristics include MyD88 and CD79A or B. There are other characteristics that can be important. The treatment is not very well developed. That is in part because the tumor is so rare that there aren't that many clinical trials. There are just not that many patients to enroll in clinical trials. But we do know some things. Dexamethasone is a glucocorticoid. It is a synthetic analog to hydrocortisol, the adrenal cortex hormone, a stress hormone. We give it in much higher doses than it would physiologically appear in the body, and then it can kill B cells. B cells actually undergo apoptosis, kill themselves when glucocorticoids bind to the intracellular glucocorticoid receptor and then move to the DNA, to glucocorticoid responsive elements. It also has other effects. The brain edema also gets better with dexamethasone. That's not an effect on the tumor cells, or at least not just on the tumor cells. It is an effect on the endothelial cells, the inner layer of the blood vessels, Those endothelial cells make something called the blood-brain barrier in the brain, which allows only very specific molecules to pass from blood to brain tissue. Only very few tissues have that type of a barrier. And in the surrounding of tumors, the blood-brain barrier is often in trouble. Then you see these things like this water in the brain edema, and dexamethasone can make that better. In total, the effect of dexamethasone is tumor gets better, edema gets better, patient gets better, and that happens very fast. But it doesn't last long. And you can't keep somebody on dexamethasone for too long, because given for long terms, dexamethasone has a lot of adverse events. It gives mood changes, depression, and it gives a diabetic metabolism, high glucose level in blood, increased blood pressure, bone substance loss, and very, very important, an artificial immune deficiency. People get infections when they are on glucocorticoids. Therefore, dexamethasone is just considered a beginning or an emergency medicine to sort of get over the difficult things. It is, in the context of clinical trials, it is considered a nuisance. If dexamethasone is given by the treating physicians together with an experimental drug and the tumor shrinks, then you don't know, was it the new drug and what did the new drug really do, or was it just the dexamethasone? But it is so effective, and these tumors grow so fast that situations where it is necessary can really not be avoided. Radiation is similarly falling out of fashion. These tumors respond to radiation. If you give radiation, they shrink away. Now, the tumor are not just in the place where you see them. These tumors often infiltrate pretty much everywhere in the brain. Therefore, when radiation is given, it is commonly given as whole brain radiation. And the doses you need to kill a lymphoma or make it go away, stay away for a while, are close to what the brain can tolerate. It is kind of more than what the brain can tolerate. And if you irradiate the brain of an elderly with the doses necessary to kill lymphoma, the brain suffers. There are cognitive deficits that occur, and you can also see it in morphology. There's just less brain in the skull. Therefore, people don't like it and only use it when the other things don't work. The other things are treatment protocols with a number of drugs, and they are organized in induction and in consolidation. Induction is the beginning where intensive treatment is given, make these things go away, but we know if this is all we do, these things will come back. So consolidation is added thereafter, and that may be a long-term maintenance treatment, or it may be something else. The drugs built into these protocols include high-dose methotrexate. That is the typical number one drug listed everywhere, but there are others. Among those is high-dose chemotherapy followed by autologous stem cell rescue as consolidation. The autologous stem cell rescue is not treatment. That is supportive care. What kills the cancer is the high-dose chemotherapy in the beginning, and you see the names of the drugs here: thiotepa, cytarabine, camustin, busulfan, cyclophosphamide are used in that context. There are further drugs used. Many of them are still classical chemotherapy, but then there are novel drugs, BTKIs, proton tyrosine kinase inhibitors, IMiDs, CAR T cells, and other drugs are tested and hopefully will bring us success in the future. Let's spend a little bit more on the number one drug, methotrexate. Methotrexate is a folate antagonist. Folate is a vitamin. Methotrexate is the first targeted drug that I know of. It was the group of drugs was originally developed by Sidney Farber in what is now called the Dana-Farber Cancer Institute in Boston. The drug is yellow. And it can be swallowed, and it can be injected, and it can be given in multiple different ways and for multiple different diagnoses. It's not only used for cancer, it's also used for autoimmune diseases like rheumatoid arthritis, and it also works as an abortion drug. When it is given in cancer, it is given in standard dose, low dose, or in high dose. About up to 1 gram per meter square methotrexate can be survived. Adverse events include liver toxicity, mucositis, thrombocytopenia. If you give more than that, you exceeded the lethal dose and the patient would die. If not, there was an antidote. There is an antidote, which is folic acid itself, also called leucovorin. And so that way of giving methotrexate is called high-dose methotrexate, and it is followed by leucovorin. High-dose methotrexate has a different kinetics than low-dose methotrexate. For instance, it penetrates the cerebrospinal fluid much better, and it also penetrates through cellular membranes, such as the B-cell membrane, better. So methotrexate is a backbone of the induction therapy for most primary central nervous system lymphoma. And how does all this treatment work? What is the outcome, the prognosis of primary central nervous system lymphoma? The publication I found that was richest in data was from Dr. Mendes, published in 2017. And he and his colleagues used databases such as the SEER database, that is a publicly funded database in the United States, your tax dollars at work. You see the survival curve that they created, and this survival curve x-axis is in months. So these 400 months here is more than 30 years of observation time. First thing you can see is even in those times, some of the patients survived. It was not an always deadly disease, but it is a miserable overall survival curve. Look how deep it comes down, which confirms the point that the disease has a large unmet need. Now, the fact that this is data from patients that are now 30, where the treatment was now 30 years ago, also gives some hope that the curves are different nowadays. And yes, they are. If you go through the literature, you can find curves that are just on 100%. Nobody died, but they are short. There are very specific subgroups of patients of typically good prognosis, and they're relatively small studies. But the truth is somewhere in between. It remains a fact that primary central nervous system lymphoma, in particular when they recur, are a disease with a poor prognosis that still needs a lot more research. This curve here has a median overall survival of 26 months. You find that when you go on the y-axis to the 50% mark, go over, find where it hits the curve, go down, and then you see you hit the x-axis in about 1/4 between 100 and there. This was as much as I wanted to say about the clinic of primary central nervous system lymphoma before coming back to our response criteria. But there are sources of information you can use to see more. And if you like videos, then those 3 are the ones that I am recommending. I like those best when I prepared for this video. This one is from Joe Mendes. He is from the Huntsman Cancer Center in Utah. This one is from James Rubinstein from San Francisco. It goes into more details of the clinical trials of the past. And the last one from this year is from Dr. Nayak from Dana-Farber Cancer Center. And I thought this one was the best in terms of lay language. If you did not study medicine, this one is probably the easiest to listen to. And if you want to know more details about diagnostics and treatment, and in particular, if you'd like to know what is really proven and what is still a dream of the medical scientific society to be proven in the future, then I am recommending the NCCN guidelines. Those are free and you have to become a member, but then you can download them. There are guidelines for pretty much every cancer. One of those guidelines is for central nervous system cancers, and that has a lymphoma chapter, very well written in very much details. but it really focuses on what is proven and therefore may appear somewhat conservative compared to what is ongoing in clinical trials. It is what is considered the standard in the United States for treatment. There is a version for layman's as well, also from NCCN. So now we're done with background. Let's go back to the main paper that we would like to discuss and start with the title. So here you see this was actually an international workshop, and it didn't just talk about response, it also standardized baseline evaluations. The authors are a long list of very strong experts of multiple fields and multiple geographic regions, led by Lauren Abrey. She, at the time, was in the Department of Neurology in Memorial Sloan Kettering Cancer Center, and she has then left academia, went to the industry, went also from the US to Europe. And maybe this is why we haven't had a follow-up paper from her, because typically in the industry, you leave the glory of publications to academia. She wasn't alone, nor were those co-authors alone. There is a very long list of names in the paper. I counted 92, and it is quite an achievement to get all these people together to work on a project such as response criteria. And maybe a second reason why these response criteria are so old and haven't been followed up. It is a very high bar. In the paper, you will find this sentence: either unidimensional or cross-sectional measurements may be used, together with the table that tells you partial response is 50% shrinkage or better. There is a reference to it, but that really only refers to a presentation. There are more modern publications, detailed publications about things like volumetry. But before you start reading this, let me bring you on a journey back to your middle school geometry. Please consider that you have a patient with a square tumor and it has 2 centimeters diameter. You give treatment 1 cycle only and you shrink this tumor to 1.3 centimeters diameter. It still is square. It clearly is smaller. Now you want to know, is this or is this not a partial response? If you measure in 1 dimension and you shrink this from 2 to 1.3, this is a shrinkage of 35%. It does not qualify for the 50% necessary for partial response. Therefore, it is stable disease. If you use 2 dimensions, the cross-sectional area, or just 2 dimensions multiplied, as it is called, the product of diameters, then you have 2 times 2, 4 centimeters square, and you shrink this to 1.3 square, which is 1.69 centimeters square. That is a reduction in size of 58%, and thus, by the definition of the table, this is partial response. Obviously, not both can be true. You cannot have stable disease and partial response in the same time point measurement. One of the two has to be true only. And that is just the definition. Do you use unidirectional or cross-sectional area? So the paper leaves you alone with this. You need to describe it in the protocol. Treatment beyond progression and pseudo-progression are discussions that occurred later than the Abrey 2005 paper was published. There are very rich discussions now. Let me explain what that means. There is a common discussion when protocols are written and the team decides what to put in there and what to not put in there, to argue around the question: should we allow treatment beyond progression? Should we allow a patient to receive our valuable new experimental drug even though the images have shown tumor progression? I mean, obviously, as sort of white belt in teaching, the beginning of teaching is you treat until you have either cured the patient or you lost the patient, or the drug isn't working anymore and you should switch, or the drug has become toxic and you should switch. But that's just white belt teaching. If you want to become a master and become a black belt, you have to go well beyond that. Why would anybody treat beyond progression. I have listed here 6 different reasons. Number 1, images are not certain. Measurements are not certain. If you take the very same MRI and you let 2 radiologists make the measurements will not be the same. Even more so if you have the same patient with the same tumor and you do 2 MRIs at the same time, one after the other, and then measure. The measurements will be even more different from each other. Number 2, this is what started the main discussion nowadays, the phenomenon of pseudo-progression. I have heard that first in the discussion around when temozolomide and radiation were given simultaneously for glioblastoma. We saw some of those tumors to look more contrast enhancing, somehow more angry, more bigger in the end of radiation, more than we had seen that before. And we called that pseudo-progression because the treatment later turned out to be the tumor shrank like they always did and even shrank better than without temozolomide. But the phenomenon of pseudo-progression became far more commonly known when real immuno-oncology drugs came around in ipilimumab, nivolumab, pembrolizumab. There, with peripheral tumors, you saw sometimes the tumor appearing bigger when the treatment was actually working. And that's not really a surprise. These treatments work by lymphocytes infiltrating the tumor, causing inflammation processes there. Those take volume. The lymphocytes themselves have a volume, and the inflammatory process includes edema and other cells infiltrating. They all take volume. So even though the number of tumor cells was already decreasing, the total volume looking on image looked bigger. Follow-up images then saw these things shrinking, and then it was called pseudo-progression. A similar phenomenon, a similar term is called tumor flare. That's more commonly used in the world of safety science, but it's the same phenomenon. There's a different reason, and that's even without pseudo-progression, a simple biology timing reason. There is time between screening image and cycle 1, day 1. In most clinical trials, this is about a month. I've participated in a trial where it had lymphoma, and they allowed 6 weeks between screening MRI and cycle 1, day 1. Tumors grow. So in the time between screening image to beginning of the treatment, they grow. If you then have successful treatment and you actually shrink the tumor, the size of the tumor when the first follow-up image is done may still be bigger than it was at screening. It's smaller than it was at cycle 1, day 1, the beginning of treatment, but you don't know that. You only see screening compared to first follow-up. So it's a good idea to carry on treatment to find out if that growth, this apparent growth, happened before or on the treatment. But even when it happened on the treatment, it could be that the drug only starts working later. There are some cancer drugs that take quite some time to work. I've seen that with BET inhibitors, and azacitidine has that as a phenomenon that in the beginning you don't see much. Sometimes, and that may be because there is damage to the DNA or other structures that doesn't hurt the cell until the cell starts dividing, and then it hurts the cancer cell and the cancer cell dies. So those drugs take a while, and then the tumor is actually getting bigger, progressive, while on treatment, yet it will get smaller if you just carry on and don't follow the dogma of discontinuing treatment when you see progression. Dogmas are sometimes important things, but they typically outlive their usefulness after a while. And the PD dogma that you cannot carry on treatment after progressive disease has reached its time to go. there are people that teach you that after PD there cannot be PR by definition, because first of all, you don't give the drug anymore, and second, if you give the drug, you don't measure it anymore, and it's just by definition. That's the dogma that has to go. Number 5, there is sometimes clinical benefits of continuing treatment even though the treatment isn't shrinking the tumor anymore, even though further waiting won't make that and getting better anymore. The medical society that has taught us that very clearly is the Prostate Cancer Society. Those people treat the prostate cancer in the beginning with androgen deprivation therapy. Cancer grows under the influence of testosterone. You take the testosterone away, the cancer shrinks. But it may not last forever, and the cancer may grow. Different from the rest of the Oncology Society, prostate cancer people keep the patient often on ADT, androgen deprivation therapy, while they add new drugs. And there is thinking and logic behind it. Cancer is heterogeneous. Now, you have some prostate cancer cells that just need testosterone to grow, and without testosterone, they will even die and the tumor will shrink. And there are others that have mutated from that, are not testosterone dependent anymore, need a different treatment to be killed. But what is in the patient is a mixture of the one and the other group, and it is useful to maintain the androgen deprivation therapy just to keep those pieces that are still sensitive to it under control. Now, that's a clinical thing. It doesn't matter much for clinical trials. But this one, number 6, is the opposite. This is only relevant in clinical trials and doesn't matter much in clinical care. It is the phenomenon that the Burke finds something not to be progressive disease. So, clinical trials after being completed are often re-evaluated by a blinded independent review committee, which doesn't know the treatment, just looks at the images and redefines what is progressive disease and what is not progressive disease. And that may be important for approval studies, studies that go to the regulatory authorities and have time to event endpoints in the event is progressive disease. The first team that looked at it, the principal investigators or whoever else looked at it, may have considered this progressive disease, and the time to progression therefore ended at that time with the event. When the Burke looks at that and comes to the opposite conclusion and says, no, that wasn't progressive disease, what do you do now? The patient is not on study anymore. This happens half a year after the patient is off. You cannot bring these data back. The only way to really know what happened and have good data is to have the patient continue treatment and then look at the next image to find out if this really was progression at the time where the event was assessed. By all those 6 reasons, it can be a good idea to treat beyond progression. There are 3 possible solutions. One is to allow treatment beyond progression and fight the dogma and say we continue to assess after PD, and when we define the best response rate, the assessments after PD will be counted. But it is an upward battle in many companies. Some people have gone other ways. They said, well, if I can't fight the PD dogma, then I'll redefine PD. That's pretty smart. And then they require confirmation of progression, very similar to the confirmation of complete response that are in the Abrey 2005 criteria, where you have to have a follow-up image to say this really was CR. They will say, well, we also need a follow-up after PD. Only if a follow-up after PD really shows this is progression, then we will call it progression. Another way to do this is to add a new category of pseudo-progression. And it will follow the same logic. With both of those, you don't need to fight the PD dogma, because the counting of responses doesn't stumble over the term PD. Abrey 2005, the paper that we're discussing yet, happened before all those problems were clear and before all those solutions have been found. The phenomenon is not discussed there at all. The paper defines the response criteria not just in the table, but there is a text paragraph or more for each of them. And this is the definition for complete response. Requires the disappearance of all enhancing abnormal gadolinium-enhanced MRI lesions, no active disease in ophthalmology exams, negative CSF cytology, and the patient must be off glucocorticoids, that's dexamethasone, for at least 2 weeks. Not in that text paragraph, but somewhere else in the paper, it also says all complete responses, CRs, should be confirmed by repeat images. It doesn't say this for the other categories. The equivalent section for this category, CRU, reads as CR-unconfirmed, CRU. Any patient who fulfills all the criteria of CR but continues to require glucocorticoid therapy. Now that's fairly clear. The other two are not quite as clear. Small but persistent enhancing abnormalities in the MRI. Almost everybody has that. And then persistent minor abnormalities in follow-up ophthalmology exams, even more difficult as there is no quantification whatsoever for this. My prediction would be that this category will disappear. For PR partial response, we again find the 50% or better decrease in the imaging. Glucocorticoids are irrelevant. The ophthalmology exam has to be better, but there is no quantification for that. And for CSF, it says similarly, it has to be negative or maybe persistent. It doesn't even say that it has to be better if the brain lesion is smaller. Now, they make specific comments about a type of disease that's called leptomeningeal lymphoma. That is when the lymphoma is detectable in CSF and possibly also in imaging, but it's not measurable there in imaging because it doesn't form a solid lesion inside the brain. For those leptomeningeal lymphoma, they say the category of PR does not exist. The response is so hard to define in those. Either everything is gone, that is CR, or there is progressive disease. We may classify stable disease, but we do not have a PR. Stable disease doesn't have its own row in the table, but it does have a sentence, a single sentence. It says stable disease is defined as less than PR, but not progressive disease. Very wise to not give numbers and define the numbers only in the other categories. PD, progressive disease, has such numbers, and it is the 25% increase that we discussed before. Also, progression of ocular disease or appearance of new lesions. Any of them. It's not an and, it's an or. This or this or this will make it progressive disease. The publication isn't just about the response criteria. There are other quite interesting pieces to read there. It gives guidelines for what needs to be done in screening, images, cytology, ophthalmology, MRI of the spine is an important topic. It defines performance scores, compares the Karnofsky score to the ECOG score, and it describes other endpoints. Now, those are time to event endpoints. Typically, response endpoints are in early oncology trials. Time to event endpoints are more common in late oncology trials, such as those that lead to approval. But the FDA has guidance that define these things quite more in detail. So I would recommend to use the FDA guidance as reading material for time to event endpoints. Here are examples of other response criteria. The Lugano criteria are used for non-Hodgkin's lymphoma other than the brain. They're published in 2007, and then 7 years later, the update. These criteria use two-dimensional measurements, and they do not require confirmation of complete response. Brain tumors are typically classified by the RANO criteria published by Wen in 2010 and the update in 2023. Between this and that, there were modified RANO and iRANO, and then in 2023, they put it all together. This paper is obviously quite recent, and it describes in great details techniques of MRI that can be used just as well for lymphoma. It also describes the phenomena of pseudo-progression in great detail and very good to read. The most common criteria of all, by my knowledge, are the RECIST criteria. They were preceded by the WHO criteria, and then Tarasin in 2000 and Eisenhower in 2009 updated them as the famous RECIST criteria. Those use one-dimensional measurements, and therefore the sum of diameters, not the sum of product of diameters, to define the time point responses. There are quite a number of modifications. There is iRECIST, which then takes pseudoprogression into account. The 2005 Abrey publication is the most commonly used reference you find in clinical trials up to today in 2024. But it isn't the last one. There was actually an update in 2021. It was also from a number of different places, a bit more European-based than the previous publication, and it focused on radiology. In the abstract of this follow-up paper, you see that they not only talk about MRI, they also talk about PET, positron emission tomography. That is a technique that has been proven to be very useful for peripheral lymphoma, even more than the MRI. There, most people nowadays do CT PET to show the metabolism of a lesion, while the MRI typically shows the anatomy better, the PET shows more information about metabolism. Furthermore, the paper also refers to 3T versus 1.5T MR systems. Those are strengths of the magnet. The MRI, the magnetic resonance imaging, creates a magnetic field around the brain and then lets it go. The molecules spin back into their original position, and that signal can be picked up. That process gives you sharper images if the magnet is stronger. At the time of the Abrey publication, most of the images were 1.5 Tesla images. Now 3 Tesla images. Machines are around and can be used. And this follow-up paper in 2021 describes how to do that. The authors then go very deep in analyzing what has been done, what is recommended from many different places on the planet and where there are data. And they end with 4 tables, 2 for 1.5 Tesla magnets and 2 for 3 Tesla magnets, and 1 table for minimum specifications and the other one for ideal specifications. And if you read those tables, they are complex to read, and I get the impression they put in the things that are necessary for clinical care, for caring for patients, making diagnoses, not necessarily necessary for determining the size change of a tumor on treatment. For this, you just need T1 weighted pre-contrast and T1 weighted post-contrast, and then you need to measure. DWI, T2 weighted images, fusion, all those things are very helpful when you want to make a diagnosis, differentiate what is lymphoma, what is scar, what is maybe glioma, and another, or where to biopsy. All those clinically enormously relevant questions can be answered much better when you have standardized and good criteria. But it may go beyond what should go in a clinical protocol, where we only should put in things that we later then analyze. Furthermore, all those specifications need to be understood by the people that write the protocols, and even making a decision which of the four tables to use almost needs a radiologist. Rarely does a sponsor for a clinical trial have a radiologist on staff. So the distribution of this paper may be a bit more challenging. Now you have heard everything that I thought I should say that was really based on facts and could have references behind it. We are leaving exact science and we are moving into predicting the unknown future. I am using my crystal ball. And I am predicting that there will be a new classification of response for primary CNS lymphoma. And in that new classification, the time for screening will be shortened. People will recommend to not have mandatory ophthalmology exams, LP, spinal MRIs, testicular ultrasound, bone marrow aspirates, and biopsies, in the interest of getting patients on trials faster. The diagnosis of primary CNS lymphoma is sometimes made in clinical practice on imaging only, and this will not be recommended for clinical trials. They will require to have some kind of biopsy or cellular diagnosis in addition to typical images. I did see in my crystal ball that the phenomenon of pseudo-progression or treatment beyond progression will be discussed in one way or the other, but the ball was somehow cloudy which solution the authors will take. Clear was the ball in the question of CRU. That will disappear. MRI specifications have been kind of missing in the 2005 publication, and they were over the top in the 2021. The next classification will find a compromise, and they may discuss 3 Tesla magnets and PET in that context. The cerebrospinal fluid findings will be described as flow cytometry and as cytology, and if the two disagree, they will tell us whom to follow. There will be something about molecular tumor markers such as MyD88 and cell-free DNA, hopefully. There may be a discussion of patient-reported outcome. Now, those are my predictions. Here is my recommendation how to check it. Go in PubMed. Look for publications that have the name Gromes and Nayak, both among the authors. I would predict you'll find that paper. And then you can put in the comments of my video if I was right with my predictions or not. And this is the last slide of this video. I want to thank many people who have discussed and taught me many things. Those thoughts became part of the video. Here are some of the names listed. None of these people has approved what I write here, so if something is wrong, those are my mistakes. The entire video is brought to you by Oncology Consulting Wolf LLC, which is a licensed company, and it is solely responsible for the content of the video. The video was triggered by work with the company Curis, but it is not sponsored by them nor sponsored by anybody else. All the opinions are personal opinions. They are not influenced by any finances. Nothing is perfect. Errors happen in spoken words and in slides. Science moves on. The video reflects the opinion of the author in December 2024. Opinions change as they move forward. I hope you enjoyed it, and I hope to see you again in the next video.